Thank you. Thanks, Ben. And thank you to Amy. Ben and I were putting the program together, it never occurred to me that I would have to come on after Amy without having time to really compose myself. I had seen that slideshow once before, and I knew the effect it was going to have on me. But we'll see what we can do here. My diagnosis differs a little bit from yours, Mrs. Olmsted, but then I'm hampered by 20 years of medical school education. What I want to try to do is maybe tie together some of the themes from the last 2 days. And if I'm really lucky, Wendy Sue, maybe I can actually do that in a way that at least begins to hint at some answers and doesn't just leave everybody sort of wondering what you're supposed to do next. And to do that, I've decided the general theme I want to talk about is trying to understand conflict situations when we find ourselves in a conflict with somebody else. And it doesn't necessarily have to be in the medical setting. What are some strategies we should think about using, and how should we understand those conflicts in a healthy way? And I'm going to do that by making 7 or 8 observations, bearing in mind that we're talking about cases with children, and we've heard about many of these sorts of cases, and I could have picked any one of hundreds of cases here to illustrate these points, but we've talked a little bit about some of these already. And they all pose similar issues, but not entirely, but always with slightly different set of facts and slightly different issues that might come up. The Baby Mueller case from Idaho has been alluded to in several occasions. In that particular case, you had two parents who brought their child to an emergency room with a concern about the fact that the baby had a fever and wasn't looking very good to them, not feeding particularly well. And the very well-meaning emergency room physician made an assessment that this baby really did need to have a full septic workup, which included a spinal tap. The parents had objections about the spinal tap. They could not reach an agreement with the physician, and ultimately the physician decided that he could not let this baby go without a spinal tap and involve CPS. Unfortunately, the mother vigorously objected, and the result was that she ended up being restrained in a different room while her baby underwent the spinal tap. Many of you know about the Riley Rogers case. Again, this was a case of a mother who had a baby with renal disease and a baby in the estimation of her physicians who needed dialysis in order to survive. Mom did not want dialysis to happen. The physicians felt strongly that they couldn't let a baby die for lack of dialysis. Mother felt strongly enough about her feelings, despite the fact that the baby had actually been removed from her medical custody, that she took her baby that happened to be smaller than a breadbasket and put her baby in her handbag and left the hospital and headed down I-5 for the frontier, Oregon, where apparently she thought maybe they didn't do dialysis. Abraham Cherex, on the other hand, is a 16-year-old, he may have been 17, I can't remember, but he was an older and very mature teenager who had his cancer relapse and was told that that would mean embarking on another aggressive regimen of chemotherapy, and with the support of his parents said, I don't want to do that. I know what it was like the last time. I know I may die without it. I happen to believe that alternative therapies might offer me some hope, and I'd prefer to follow that course of therapy and not undergo chemo. And his case ended up in the court systems in Virginia, with the ultimate resolution being that the courts felt Abraham Cherex was in fact a mature minor, and with the support of his parents should be allowed to embark on the treatment regimen that he chose. So these all have several things in common. And I want to make some observations with those sorts of cases as a background. And the first point I want to make is that it's important when we talk about cases like this and think about cases where there are conflicts that conceptually we characterize them correctly and we characterize what we're talking about correctly. One of the ways we, I think in a flawed way, characterize cases like this is we frequently talk about them as a classic case of autonomy versus beneficence. And I've done this experiment with lots of audiences, and I've asked them to characterize the Riley-Rogers case or characterize the Abraham Cherek's case, and inevitably the bulk of the group feels that this is a classic case of the parents exercising autonomy and apparently the physicians and healthcare providers exercising beneficence. The point I want to make here is that these are not cases about autonomy versus beneficence, and if you think about them as cases of autonomy versus beneficence, it changes the way you approach them and think about them in a way that I'm not convinced is healthy. These are cases about beneficence. Beneficence is the ethical principle that says we should do good to others in its sort of simplest form, and that means avoiding the infliction of unnecessary harms, preventing harms when we can do so, and promoting the good of the other person, and in medical situations, the patient. Medicine is a form of applied beneficence, and by medicine I mean to encompass all of the healthcare professions, not simply physicians, but nursing and occupational therapy and recreational therapy and nutrition, and everybody who sees it as their job to optimize the good of the patient in the hospital. And there's no question that when the physicians in Riley-Rogers' case said Riley needs dialysis, they did so out of a sincere feeling that this is what beneficence demanded. Likewise with Abraham Cherek's physicians, and likewise with that emergency room doc who found himself confronted with baby Mueller. What we need to recognize, however, is that parenting is also a form of applied beneficence, and that it was not simply the case that Abraham Cherek's was exercising his autonomy, it was not simply the case that the Mueller family was exercising autonomy. What they were doing was saying, we think the best thing for our son is not to have another course of chemotherapy. We think the best thing for our baby is not to have a spinal tap, and we have our own reasons for believing that. When you recognize that these are cases of disagreements over how to apply the principle of beneficence, it becomes much more apparent that these are value discussions, that the science of medicine can help us determine, for example, what are the odds of meningitis for baby Mueller, how likely is baby Mueller to have meningitis, and how likely is a spinal tap to help us diagnose that, and what are the other alternatives to doing that, and what are the consequences, and so on. But what it can't do for us, what the science of medicine can't do for us, is tell us, okay, so given the fact that his chances of meningitis are less than 1%, and given the risks and benefits of a spinal tap, how do you line those up against each other? And how do you come to an agreement about that? And what's happening in those cases is that the parents disagree with your assessment as a physician or a nurse or whoever it is that they're talking to. In that equation, the parents may be weighing other spheres of goods. As healthcare providers, we frequently focus somewhat exclusively on what we consider to be the medical benefits, but we may be forgetting the fact, Abraham Cherek's may be a good example here, that there are other issues that he may be thinking about other than what are the odds that I might survive with chemotherapy versus die. He's taking other things into consideration. And it may be that he's quite willing to see his life ended in a year or two by foregoing that, given sort of what he sees as maybe the best way of optimizing his quality of life. And so these trade-offs are important, and it's important for healthcare professionals in particular to recognize that they are trade-offs that have a very strong values component. The reality is that things can look very differently depending on where you sit in relation to the issue that's being discussed. This is going to hurt like hell. Now, what the physician says is, you're going to feel a little prick, or you're going to feel, but this is what the kid is thinking. Observation 2, we engage ethical issues and dilemmas at different levels, and the level of engagement matters. I would argue that one of the mistakes we sometimes make in thinking about ethical issues is we don't pay attention to where we sit in relation to that issue, and it matters. I suspect the people in this room are a little more sophisticated about this, but I certainly see this mistake made commonly in public policy decisions and discussions. What do I mean by this? What should I do? Abraham Cherix and his parents have to decide what the morally and otherwise right thing to do is in his case. That's their problem. It's their ethical dilemma. It impacts them in a way that it impacts nobody else. Now, it may be that once that disagreement arises, that Abraham Cherix is faced with a disagreement with his physicians, that I am called in as an ethics consultant, for example, and one of the questions I'm asked is, well, what do you think she should do or he should do? But I'm sitting in a very different place, and it's important for me to recognize that. And then there's a third question, which is, even if I disagree with Abraham about this, am I going to tolerate his decision anyway? And then finally, there's that level of should we make a rule. So to make this more clear, let's think about immunization refusals and immunizations in general. I had to face those questions at the primary level here. What should I do? I have 2 kids. I needed to decide whether I was going to get them immunized, how that stacked up, and I made the decision for my kids that the right thing to do for my children and for other people was to get them immunized. And I'll be perfectly honest that in my calculation with the varicella vaccine, I decided it was not necessarily in the best interest of my child to get her vaccinated at that point in time. But my daughter's best friend was a little girl with leukemia. And so we decided that the right thing to do is to immunize her, even though we're not convinced it's the right thing from a sort of best interest perspective at this point in time. That was our ethical dilemma. We faced that at a primary level. In facing that, I may have asked somebody, what do you think we should do? And that's what happens all the time as a pediatrician or as a nurse practitioner or as a public health professional. The family says, we don't think we should get immunized. And you're one step away, and you may say, well, I really think that's wrong. I think the best thing for your children and for the public is that you get immunized. And that's the way I feel. Not only do I think immunizations are best for my children, I quite frankly think they're best for most children. However, if the question I'm faced with is, should I tolerate their decision, the answer I will give is yes. Most of the time I should. In other words, I've got a patient sitting in front of me. They say, we're not going to allow you to immunize our child. And I say, I think you're making the wrong decision. I think you should rethink this. I disagree with you. That does not translate into the fact that I'm going to call CPS or do something else that would represent an intolerance for their decision. I think that's an acceptable decision for them to make, even though I may think it's the wrong decision for them to make. And then there's one more level. Should we have a rule? Should we have a rule? Do we feel so strongly that we shouldn't tolerate certain decisions that we actually pass laws that say we won't tolerate those sorts of decisions? Why is this important? It's important primarily so that people recognize that just simply because you don't believe in X or you think this sort of decision is wrong, it does not follow logically that you then try to interfere with somebody who's deciding other than you would. It's perfectly consistent, for example, to feel that physician-assisted suicide, abortion is wrong, and yet not feel that there should be laws that outlaw those sorts of things. Observation number 3, and Lainey Ross alluded to this and nicely set me up in this arena. Best interest may not be the best standard for institutions to use when we talk about what we should do with parents who may not see things the same way we do. We know that as a general rule, parents have moral, social, and legal grounding to make decisions for their children. We consider what they give us as permission. It's not technically consent because they're not giving permission to do something to them, but to a third party. And what we commonly hear is that the discretion that parents have to make decisions for their children is limited by the best interests of the child. The argument I want to make is that we need to understand what we mean by that. I think best interest is a perfectly fine standard to suggest to parents as they try to make hard decisions for their children. How should I make this decision? You should think about what's in the best interest of your child. I have no problem with that. Where I have a problem is in telling the rest of us that the grounds for interfering with a parental decision is because it somehow crosses this boundary of the best interests of the child. Now, why do I feel that way? The best interest standard, first of all, I do want to point out that the best interest standard does not have its origins in health law. It has its origins in family law, and it's frequently in family law surrounding a fairly dichotomous decision, which is, okay, which parent do we put the kid with? How do we place this child? One or the other. You can kind of do a mathematical equation there. Not entirely, but I mean, you got two choices, and you try to figure out which one is going to be best for the child. Medical decisions are rarely that simple. But nonetheless, the standard has been adopted, and it's the one that we use in legal and ethical settings. Say we use, and I'm going to get back to that. Brock and Buchanan define this as acting so as to promote maximally the good of the individual, and Beecham and Childress define it as a surrogate decision maker determining the highest net benefit among the available options, assigning different weights to interests the patient has in each option, and discounting or subtracting inherent risks or costs. I love Beecham and Childress, but quite frankly, this sounds like a philosopher. You can't make a mathematical equation out of these things. I mean, the physicians and the nurses in the audience, I'm sure, are going, how do you assign those values? You just can't do it. It's not this easy. The best interest standard, first of all, is very difficult to apply. It's often difficult to define what actually constitutes the best interest of a child in the medical setting. It's inherently a question of values, which I alluded to in my first observation, and very difficult to sort of objectively measure and calculate. The nature of interest can be very complex. Even decisions, many decisions, for example, about, well, let's go to the Riley Rogers case and sort of establishing who should have custody to make decisions of Riley Rogers. If you actually remove Riley from his home in order to accomplish this, you now have a harm that's occurred. You've taken a child out of a home and severed some bonds that are important, but how important are those? I mean, how do they stack up against not getting dialysis for kidney disease? I don't know the answer to that, and I'm not sure anybody has the answer to that question. The nature of interest is very complex. We also, quite frankly, don't expect parents to act in the best interests of their children, and Lainey pointed that out very nicely with her example. My kids would rather have me home today, too. They also vigorously object if I suggest that they jump in the car so I can run and get my morning coffee at Starbucks. They'd rather be at home playing, and it's certainly not in their best interest for me to drive onto Bothell Way and risk the traffic and the speeds that people are driving so that I can get coffee in the morning, and yet I do so occasionally. We don't expect parents to send their kids to the best educational institution. We don't expect them to optimize their safety in all respects. If that were the case, we'd probably require that concrete barricades surround every yard so that stray cars couldn't potentially go into the yard and pick off their children while they're playing in the front yard. We certainly wouldn't allow parents to let their children watch television. And it's questionable whether we would allow them to go shopping with their parents. Let's face it, we do not require parents always to act in the best interest of their children. I would also posit that I think it's a bit hypocritical for a society that clearly does not hold the interests of children up front as an important value to then require parents to do so. One of the great paradoxes in my mind is that we could potentially force a parent, for example, to undergo a horribly expensive surgical treatment that they have decided is not what's best for their child, and then make them pay for it, which is exactly what we would do in this country. Quite frankly, I think other industrialized nations who have some kind of universal healthcare system have much stronger grounds for making that kind of demand on parents than we do. If we really felt strongly about the best interests of children, we'd have a minimum wage that made it reasonable for parents to raise children. We would optimize our educational systems in a way they're not optimized currently. We would have universal health for all children. We would provide child care for parents who have to work. And we would do something about the pollution problem in urban areas where largely poor people have to live, and those children then suffer the effects, which include asthma and everything else. So we're a bit hypocritical about this. The bottom line is the courts don't even use best interests as their standard. Oh, they say they do. You can read their opinions, and they say they do all the time, but quite frankly, if you read between the lines and look at the standard they're actually applying, it's not a best interest standard. The reality is it's frequently modified to become something else, even while they retain the name best interest standard. The reality is they place a very high burden on the state to prove that medical treatment is necessary before compelling treatment over parental objections. And in Ken Wing's words, the courts have been reluctant to require medical treatment over the objection of parents, except where immediate action is necessary or where the potential for harm is rather serious. That's not the best interest standard. Why does it matter? Because language is important. The most common misunderstanding I face when I do ethics consultations is that I'm faced with a provider who says, well, this is clearly in the child's best interest. And yet that doesn't answer the question as to whether it's okay to interfere to the level of getting a court order. So what should the standard look like? I would argue that the harm principle makes sense. What's the harm principle? This was also alluded to this morning. John Stuart Mill and On Liberty, which some people would argue is the document in which our laws are based. Liberal democracies hold on to this tenet. The only purpose for which power can rightfully be exercised over any member of a civilized community against that member's will is to prevent harm to others. His own good, and presumably her own good, either physical or moral, is not sufficient warrant. So what about motorcycle helmet laws? Doesn't that violate the harm principle? Well, it's interesting, because if you actually look at the grounding that was necessary to establish a basis for motorcycle helmet laws, it is rarely that it saves lives. It's that it saves the public money from the trauma victims that result when they don't wear helmets. In other words, it's harm to others. It's not harm to that person who's made the individual choice. It's that it costs you and I money when they hurt themselves and have head injuries instead of just broken bones. When can state action be justified under the harm principle? Joel Feinberg has laid out 3 principles. That state intervention may be justified when the individual, in this case, let's say the parent, makes a decision or does an action that places others, in this case, let's say the child, at substantial risk of serious harm. There's the standard. It's not best interest, it's substantial risk of serious harm. The measure we use in deciding whether we should seek a court order, whether we should interfere with a parental decision, should be that the parent is placing their child at substantial risk of serious harm. Riley Rogers' mother was interfered with in her decision not because what she was doing wasn't in the best interest of her son. She was interfered with because it was in the best estimation, given the data we had, she was placing her child at substantial risk of serious harm, i.e. death, by not having him undergo dialysis. State action must be effective in preventing the harm. You can't do this unless what you're proposing actually is likely to work. And no other options less intrusive to individual liberty are available. One option, I would suggest, might be to try to convince the parent that what you're suggesting actually does make good sense. How do you define a harm threshold? Now, I'll readily admit that defining the threshold can be as difficult as defining what best interest is. And some people have made an effort to do this. Lainey Ross, who is no longer with us, I mean, she actually is sort of in this world, but like the rest of the speakers, has gone on a cruise or something. Lainey argues that it's the deprivation of basic needs, that where you cross the line, again, it's not best interest of the child, it's where a parent is actually depriving their child of basic and important needs. Joel Feinberg would further define it as interference with the interests necessary for more ultimate goals, like physical health and vigor, integrity and normal functioning of one's body, absence of absorbing pain and suffering or grotesque disfigurement, minimal intellectual acuity, and emotional stability. And the American Academy of Pediatrics just left it at substantial risk of serious harm. The bottom line, the point I want to make is that when we're faced with that sort of third level of decision making, which is not what would I do in this situation, it's not what do I think she should do in this situation, but rather, is this disagreement we're having sufficient that I can actually justify state intervention via CPS or a court order? And I would argue that we ask the wrong question when we ask, is this intervention in the best interest of the child? The question should be, does the decision made by the parents significantly increase the likelihood of serious harm as compared to other proposed harms? And I have provided a paper where I lay this out in more detail for you to read, because the purpose of my talk was not to spend a lot of time on this particular point. But I have added actually a few conditions that I think should be in place to Feinberg's. Not only should the action place a child at significant risk of serious harm, that harm should be relatively imminent before you decide to invoke CPS or a court order. Interference should be necessary to prevent the harm. It should be likely to prevent the harm. It's never justified, in other words, for experimental procedures or procedures that don't have any data to back them up. And it's not associated with a similar risk of similarly serious harms. There should be no less intrusive alternatives. And then two other things I think should be in play here. The first is that what I call and others have called the test of generalizability. You should be willing to make the same decision for other people. This is sort of a backhanded way of saying it should not matter that religion and culture are behind the decision the parents are making. We don't interfere with Jehovah's Witnesses who are refusing blood for their children because they're Jehovah's Witnesses. We interfere with those decisions because they place the child at substantial risk of serious harm. If you're going to make that decision for a child whose family happens to be Jehovah's Witnesses, it better be the same decision you would make for a family whose parents are biology professors at the university. The reason shouldn't matter. It's that they're placing their child at substantial risk of serious harm. The Christian Science cases we mentioned earlier today, too. It's not that they're Christian scientists that you interfere with, perhaps think about interfering with some of the decisions for those children. If they're denying insulin for diabetes, it's easy. They're placing their child at substantial risk of serious harm. We know that insulin will prevent that harm. There's good data to support that fact. And we also know that the huge majority of children who are denied insulin in that setting will die. That meets the threshold criterion. Finally, there's a test of publicity. And this may be more of a message for institutions than others. And that is, you should be willing to have other people know that this is the decision you're making. In other words, if you're going to get a court order to treat Riley Rogers, you should be perfectly happy that the press knows about it. Because if you really had good reasons for doing it, you should be able to defend those in the public forum. And so there should be no sort of sense that we somehow need to hide this. If you really can justify it, you should have no problem with it becoming public knowledge. This is the view from the top of Mount Olympus in our Olympic National Park. If you're thinking about doing a day hike there, forget about it. 17 miles, 8,000 feet of elevation gain, and technical climbing. But if you want to do it, I'll talk to you afterwards. Observation number 5, adolescents should be treated with respect and taken seriously. Abraham Cherek's 16 years old. He's a smart guy. He's mature. Matured probably a great deal because he's been struggling with cancer for several years. We may not necessarily agree with sort of the way he thinks about sort of treatment and so on, but the fact of the matter is he's a smart guy, he's a big guy, he's a mature guy, and he's got the backing of his parents. You need some profound reasons to be willing to compel him to undergo treatment as far as I'm concerned. This is Abraham. We do make the presumption that people like Abraham are incompetent. But there's developmental evidence to suggest that certainly when kids sort of get to the 13, 14-year-old age level, that they have begun to develop, and in some cases developed, an ability to sort of think through issues that is not that far from what it is among adults. And frequently the thing they're lacking the most at that point is simply the wisdom of experience. But I certainly can tell you from experience, as I'm sure many in the audience can, that there are plenty of kids with muscular dystrophy and CF and asthma who have struggled with those conditions, who are 10 and make decisions that are wiser than a lot of adults I know in the medical setting. So capacity is relative, and it varies from person to person, and that needs to be respected. It's profoundly disrespectful to say to a 16-year-old, we don't care what you think, we're going to force you to undergo this treatment. And as I point out to my oncology colleagues every once in a while, what are you going to do, tie them up? I mean, you're talking about 2 years of treatment here that require IVs and lines. I mean, are you going to strap him to the table? Of course you need his assent. He needs to cooperate with this if it's going to work. And the only thing you'll accomplish by not recognizing that is doing a great deal of damage and showing him a great deal of disrespect. So it's going to be hard work, but you're going to have to do it. And capacity is relative to specific tasks. It's ridiculous to talk about capacity in a general sense. I mean, as I pointed out earlier, there are certain decisions that kids of a certain age are very competent to make and others that they're not, and that's going to depend from child to child. My 11-year-old and my 8-year-old are very competent to make certain kinds of decisions, but they're not competent usually to make complex medical decisions. They may be in 3 or 4 years, but they're not right now. But there are decisions that, you know, God forbid, I think I could make them better than they could at this point, and I would suffer the consequences if I tried. The word about dissent I want to make is just simply that children are owed respect too, that the principle of respect for persons does not kick in when somebody turns 18, that you can show profound disrespect to 7-year-olds and 5-year-olds, and we need to remember that when we deal with those kids. That doesn't mean they get to trump their parents' decisions. That doesn't mean that they hold the veto card. But what it does mean is it's just simply not okay to hold them down and do things without having involved them in the decision, without having explained to them what's going to happen, and if it does have to come to that, if you actually do need to use force, recognizing that that's an assault. And it's just as much an assault on a 7-year-old as it would be on a 23-year-old. And as far as I'm concerned, that should be accompanied by an apology. Not necessarily while you're doing it, but after the fact. This is Lake Chelan in the eastern part of the state. Observation number 6. What about unreasonable parent demands? The sort of thing we spent more time talking about yesterday. And I put that in quotes because we're talking about the kinds of things that a parent may ask that I, as a medical professional, may not. What's the most common one I face? Well, it's the child who ran full tilt into the wall yesterday, banged her head, and got up, you know, cried a bunch, and the parents come in and they want a CT scan. Now, I'm not sure that I feel it's justifiable in that case to irradiate that child's brain to do the CT scan when I'm convinced clinically that there is no reason to do so. So I may not agree with the parent's decision about whether to do that. What do you do in those situations? Here's some suggestions. You might consider accommodating the parents, even if you think you know, it's way off the grid in terms of the way you practice. When the intervention's not going to harm the child, when it doesn't significantly harm others, and when the potential for, and certainly when the potential for benefit is possible, even if it's not established. And so certainly in the realm of complementary and alternative medicine, I think we have become better at accommodating those sorts of requests, even if not necessarily replacing them, or allowing them to replace our therapies. We certainly have made an effort to accommodate them. Norm Foss comments about the Christian Scientists. I don't think Norm intended to suggest that we shouldn't be perfectly accepting of the work of Christian Science practitioners. What he was saying is you draw the line at where that limits the ability to offer established medical treatments for children with life-threatening conditions. And I do think it's appropriate to limit interventions to those within the scope of a provider's practice and standard of care, and I think that's for as much for pragmatic reasons as any. I mean, I quite frankly, get uncomfortable when I'm being asked to prescribe something that I'm not familiar with and don't understand the side effects for. And I think parents, in most cases, will understand if that's explained to them. Observation number 7. Procedural justice is important. There needs to be a process for resolution of disagreement that's fair. When these disagreements cannot be resolved through respectful dialogue between providers and patients, our families do need some way of adjudicating those disputes. And that may be in the form of an ethics committee like the one we have at my institution, which is seen here at one of our monthly meetings. And this is often the way we feel. One of the things we need to do, though, when we think about those things is and I think our priority ought to be in ethics and with ethics committees and as providers, is at a minimum try to understand why we're having this disagreement. This is the shiprock. It's an impressive geologic structure. It rises 1,700 feet off the desert floor in New Mexico. You can see this thing from 75 miles away as you drive across the desert. You can see it from the Mesa Verde Plateau when you're in the national park, where it's at least 75 miles away. It's an impressive thing. It's beautiful. It's also a source of conflict. It sits on Navajo land, and Navajos believe this is one of their sacred mountains. They believe this is what's left of a sailing vessel or some kind of vessel that rescued them from their former enemies and brought them to their current homeland in the deserts of the Southwest. And so they worship this mountain. It's also an icon for the rock climbing community. Those fluted walls are hard to resist. And no self-respecting rock climber doesn't want the shiprock on there, sort of as a notch on their belt. The problem is, the Navajos will tell you you don't climb a sacred mountain. And so you have two groups that are in conflict about how to respond to the shiprock. Now, I use that example to illustrate that when we talk about the moral life and when we try to understand moral disagreements, it's not sufficient to simply try to look at and dissect one's action and response. The rock climber's action and response is to climb the mountain, and the Navajo's is to worship it. And yet, you're not going to understand the roots of that conflict unless you understand two things about those groups. The first is how their character and identity forms the way they respond to the shiprock, and the second is their vision, how they see the shiprock. And I'm going to focus primarily on vision here because I think that's an area that we need to think more about. But briefly, the Navajo, when you're a Navajo, there are certain things that are a part of your existence, and one of them is that obviously you show respect for your sacred icons. And so any self-respecting Navajo is going to feel that it's wrong to desecrate the shiprock. Likewise, anybody who sees their identity as a rock climber is not going to understand how you could possibly not want to climb that thing. But it's also true that they both see something different when they look at the shiprock. Now, there's an objective reality there. You can describe that thing from a perspective of mineral content. I can photograph it and it'll look similar from day to day. But the reality is, when I look at the shiprock, I do see something different than a rock climber sees, and the rock climber sees something different than the Navajo sees. Because although we're all looking at the same objective reality, the Navajo sees a sacred object, and their response is to step back and worship. The rock climber sees a challenge, and their response is to make a beeline and climb it. And I see a photographic opportunity. So I drive around it, looking for the best lighting and the best angle and everything else. And if I can get a rock climber on the mountain, that's even better, particularly if there's a Navajo chasing him. So there's another cutesy little story that illustrates this very well. There's a battleship out at sea. It's getting dark. There's a fog settling in. The captain comes up on the bridge and says to the lookout, "How we doing? Any problems out there that I need to know about?" And the lookout says, "Well, we got a light on the starboard bow, and it looks like we're on a collision course with that ship. And so the captain says, okay, well, signal that ship to change course 20 degrees. So the lookout does that, and the light blinks back, you change course 20 degrees. Well, the captain doesn't like being disobeyed, so he says, signal that ship, I'm a captain, change course 20 degrees now. And the light blinks back, I'm a seaman second class, which does not outrank a captain, by the way. You change course now. So the captain, now you could argue blinded by fury, says, signal that ship, I'm a battleship, change course now. And the light blinks back, I'm a lighthouse. Now, we had a conflict there, and I'm guessing it's not there anymore. And there's a reason for that, and that is that the captain has had his vision corrected. That was the problem. And there are certainly cases where we have conflicts with patients where somebody needs their vision corrected. Don't get me wrong, it's not all the time, it may not even be most of the time. But as an ethics consultant, as a clinician, there are clearly times where the problem here may be that either you or the patient just simply doesn't understand the situation the way it needs to be understood. Sometimes it's the case that the two of you just simply have such radically different ways of looking at the world that you're not going to come to resolution. And I think that was illustrated a little bit at our panel discussion with the discussion between Norm Faust and some of our Christian Science practitioners. They have radically different ways of looking at this situation, and it's important to recognize that that's where the problem lies. Stanley Hauerwas describes ethics consultation as, and you don't have to read all of this, the most important point here is that it seeks to help us see what we see every day, but perhaps fail to see rightly. I think where ethics can provide the most help in the office setting, to the clinician struggling with a patient who disagrees with them, to a patient who's struggling with a physician or a nurse practitioner or another clinician who disagrees with them, is recognizing that one of us may not be seeing things correctly. And since Norm Faust can read Mark Twain, I certainly can read C.S. Lewis. And I wanted to end with C.S. Lewis, in part to illustrate this point, because I think this is largely an unrecognized aspect of ethics, that this recognition that what's behind a lot of our disagreements is just quite simply that we see things very differently than the person we're disagreeing with. And if you hope to have any kind of a respectful dialogue with that person, your first step can't be to argue with them. It has to be to try to understand how they're seeing this situation and how does that differ from me. So to set this up, in the Chronicles of Narnia, C.S. Lewis's book, The Magician's Nephew, what you need to understand is the kids have discovered this magical kingdom of Narnia and the way to get there. And in the process of going, their Uncle Andrew, who's kind of a bad guy, ended up sort of holding on to one of the kids as they went into Narnia, and so he ended up there with him. And so this is what C.S. Lewis says. We must now go back a bit and explain what the whole scene looked like from Uncle Andrew's point of view. Now, this is understanding that what the kids have just seen is this magical creation of this wonderful sort of other world. For what you see or hear depends a good deal on where you're standing. It also depends on what sort of a person you are. You can see the character identity and the vision thing here. When the lion had first started singing, the lion is sort of the godlike figure of Narnia. Long ago, when it was still quite dark, Uncle Andrew realized that the noise was a song, and he disliked the song very much. It made him think and feel things he did not want to think and feel. Then, when the sun rose and he saw that the singer was a lion, he tried his hardest to make believe that it wasn't singing and never had been singing, only roaring as any lion might in a zoo in our own world. Of course it can't really have been singing, he thought. I must have imagined it. I've been letting my nerves get out of order. Who ever heard of a lion singing? And the longer and more beautifully the lion sang, the harder Uncle Andrew tried to make himself believe that he could hear nothing but roaring. And this is the line I love. Now, the trouble about trying to make yourself stupider than you really are is that you very often succeed. Uncle Andrew did. To go back to a couple of philosophers, you can see the same theme played out in Katie's book, Moral Vision. Moral differences are not just different choices given the same set of facts. They are differences of vision. Moral views are less the product of reasoning and more the result of an image, a slogan, or a metaphor. And from Iris Murdoch, moral differences look less like differences of choice, given the facts, and more like differences in vision, more like a total difference of gestalt. And I think the important message for those of us who practice medicine and those of us who practice bioethics is that you're not going to resolve ethical differences and conflicts unless you can first try to understand how you're seeing the thing differently than the person you're having a disagreement with. And I would argue that that's the most important takeaway point. This is an ethicist on Mission Impossible, trying to shine a light in a way that makes the issue clearer for the individuals involved in the conflict. And this is what you'll be doing an hour from now. Any questions? If there are no questions, and I see none, just a couple of announcements before you go. You're probably completely sick and tired of hearing about evaluations, but we really, really, really do want them from you. And you can win a gift certificate from REI or Starbucks or Amazon for turning them in today. That's not guaranteed, but one of you will walk away with that. Don't forget, if you failed to sign the CME or the CLE forms and you want CME or CLE, make sure you sign up before you leave. And a reminder that next year we will be doing this again. It'll be our 4th annual conference, and the title for next year is Predicting the Future, Genetic Testing in Children and Their Families. That's going to be here at the Bell Harbor Center. It's going to be a Friday and Saturday, July 25 and 26, 2008. And I think you have a flyer in your packets that you can take home with you and remind you of that. Thank you all for coming. And enjoy the afternoon.